Hello everyone. Let's study the new content. Adrenergic drugs. These drugs mostly increase the function of the alpha-beta adrenergic receptors. So they are caused by adrenoreceptor agonists. And they are based on their structure, they are also amines, and their effects also is similar to the effects of increased sympathetic nerve tone. So they are called by sympathomimetic amines. So here I hope you can understand the name of these drug families: adrenoreceptor agonist, sympathomimetic amines, or adrenergic drugs. Okay, before you study the drugs, I also help you to review the effects of adrenoreceptor subtypes on different tissues. Now look at alpha-1 receptor. It resides in most vascular smooth muscle. Once it is activated by agonist, the effector cells response is contraction. So in the blood vessels, usually it induces vasocontraction, so contribute to increased blood pressure. It also makes the contraction of pupillary dilator smooth muscle, or the sphincters in GI tract or GO tract. It also induces contraction of the smooth muscles. So on the eyes, it can dilate the pupil size, can dilate the pupils. Alpha-2 receptor, it's just in adrenergic nerve terminals in the presynaptic membrane, and its function is inhibition of neurotransmitter release, not epinephrine, even acetylcholine. So it is a negative feedback in the regulation of neurotransmitter release. It also locates in insulin. Islet beta cells, so promotes the insulin release. Beta receptor, beta 1, it mainly in heart and kidney. So in the cardiac cells, once it is activated by agonist, it has positive effect on the heart, increase the cardiac contractility, increase heart rate, increase AV conduction. In the kidney, it can promote the renin release, so increase the effects of RAAS. Beta-2 receptor, it also mainly distributes in smooth muscle, especially respiratory system, trachea smooth muscle, and uterine and blood vessels. The effect on the smooth muscle caused by beta-2 is opposite to alpha-1. This promotes smooth muscle relaxation. So, act on the blood vessels, induce vasodilation is opposite to alpha-1. And this beta-2 also resides in liver and pancreatic islet beta cells. So it is related to metabolism, especially increased blood glucose, and this also related to alpha-1 receptor and increased the lipolysis, so increase the oxygen consumption of the tissues. And the beta-3 receptor, it also mainly in epithelial cells, so increase the lipolysis. This result also related to beta-3 receptor, including beta-1 and alpha-2. Here, I also should introduce this dopamine 1 receptor. In peripheral tissue, this receptor also can be activated some adrenoreceptor agonists. This receptor resides in smooth muscle, especially blood vessels in kidney, and the effects of activation by some agonists, dopamine 1 receptor induce vasodilation of the blood vessels, especially in the kidney. So can you guys? Vasodilation, this response in the kidney. What is that result? Yeah, increase the blood flow to the kidney, so increase the urine production. Yeah, it's good effect to promote urine production. Okay, now actually I think you can understand the JAK effects. It is always determined by the JAK chemical structure. So there is a relationship between the JAK effects and JAK structure. So here, in this chapter, I will try to introduce this relationship by using these JAKs. In this chapter, you will study many agents. They are adrenal receptor agonists. Their structure are similar. So they have similar effects, mimic sympathetic nerve function. This is, most adrenal receptor agonists are derivatives of phenylethylamine. This is the basic structure, catechol. So once the adrenal receptor agonist has this catechol, the basic structure is a benzene ring, and it also has a lateral chain. And once in the benzene ring, the third and fourth carbon, if they have two HO group, hydroxyl, if they have these two hydroxyl on the fourth and third carbon, this substance are called by catecholamines. This is catechol. Because of these groups, these catecholamines has several characteristics compared with non-catecholamines. Yeah, just because of this catechol, they are high potency. They have higher potency, more potent than non-catecholamines. And it also determined by this structure. They can be rapidly inactivated by enzymes. So their half-life are very short. Their half-lives are very short. And has a poor penetration into CNS. They cannot pass across BBB, so mainly act on the peripheral tissue, has very few effects on the CNS, just mainly act on the peripheral tissue. Now, the common catecholamines include norepinephrine, neurotransmitter, and epinephrine, the main substance released from adrenal medulla, and isopreterenol. Actually, these three substances, they all have another name, like noradrenaline. Epinephrine also caused by adrenaline, and this isoprenaline. Yeah, this also caused by isopreterenol. And dopamine, it is a structure. It also has this catechol, so it also is one catecholamines. Yeah. This is lateral chain, a substitute on the amine nitrogen. This change determine beta selectivity. So compared with non-epinephrine, epinephrine has relatively higher effect on beta receptor. This mainly activate alpha receptor. Now look at this. Compare with this non-epinephrine. This lateral chain is like this. So isopreterenol mainly activate beta receptor. Now this one, dopamine, can activate both beta 1 receptor and alpha receptor. Okay. Non-catecholamines. Now look at it. Just this one, just one hydroxyl and both disappeared. So these substances are non-catecholamines: phenylephrine, ephedrine, amphetamine, methoxamine. These are non-catecholamines. Just now, I said catecholamines has their own characteristic compared with non-catecholamines. So non-catecholamine, because this structure disappeared, so they has relatively lower potency and metabolism relatively slower, so they has relatively longer half-life, and maybe they has relatively higher permeability into CNS, so they have a little effect on the CNS, like ephedrine. It has a similar effect on CNS. Okay, actually, the mechanism of action of the adrenoreceptor agonist, most of these agents can induce direct action on these receptors. So the direct acting agonists include epinephrine, norepinephrine, isoprene, prostarenol, and phenylephrine. Yeah. These are direct action drugs. Indirect acting drugs like cocaine and amphetamines, these two drugs can block the reuptake of norepinephrine. It is the main way for the inactivation of neurotransmitter, and cause the release of norepinephrine from the cytoplasmic pores or vesicles of adrenergic neuron, so promote the neurotransmitter release. So finally, based on the increased concentration of norepinephrine, this neurotransmitter can activate alpha and beta receptor, so induce some effectors functional change similar to this substance. Next action agonist, such as ephedrine. This drug can both stimulate adrenoreceptor directly. It also can release norepinephrine released from adrenergic nerve. Yeah, so it has mixed action. Okay, these are the mechanism of their action, and based on the selectivity to the receptors, the drug can be divided into alpha receptor agonist, alpha beta receptor agonist, and beta receptor agonist. This classification of adrenoreceptor agonists are similar to the classification of cholinergic agonists or blockers. Now, look at alpha beta receptor agonists include adrenaline, dopamine, and ephedrine. In this group, adrenaline, it is the representative drug. Alpha receptor agonists include noradrenaline, matriliminal, and phenylephrine, and methoxamine. Noradrenaline is the representative drug in this group. And the beta receptor agonists include isoprenorenal, dalbutamine, salbutamine. I think now you are clear. Isoprenorenal, it is the representative drug in this group. So I will introduce these three agents in much detail, and other agents I will introduce a little. But these two drugs, because they are commonly used in clinical practice, so I also will introduce this relatively more detailed. Okay, so what are the effects, clinical uses, and the adverse effects of noradrenaline? You will study this one first. Let's go and study alpha receptor agonist. The representative drug is norepinephrine. This drug also has another name. You should know well this, noradrenaline. So it also has two abbreviations, NE or NA. This drug effects based on the activation of alpha receptor and beta 1 receptor, although it is caused by alpha receptor agonist. But actually, this drug also can activate beta-1 receptor. But at the therapeutic dose, effects on beta-2 receptor is really, really weak, so usually it is ignored. Maybe they activate alpha receptor, so try to think of the distribution of the alpha receptor. It mainly resides in blood, many smooth muscles, especially blood vessels. So remember this. Once it is activated by agonist, induce contraction of blood vessels. So in the blood vessels, alpha receptor activated by norepinephrine usually induce vasoconstriction, especially in small artery or small vein, because compared with other blood vessels, this small artery and vein has relatively higher density of alpha-1 receptor. And do you still remember this? Actually, I introduced the blood vessels in different tissue. They have different density of alpha-1 receptors. Compared with the other tissues, the blood vessels in cutaneous and mucous membrane, it is the highest. And some splanchnic blood vessels, especially in kidney. The blood vessels in kidney, it also has very higher density of alpha-1 receptor. And then liver, mesentery blood vessels, and the blood vessels in skeletal muscle, the density of alpha-1 receptor is the least. Usually, blood vessels in skeletal muscle, mainly it is regulated by beta-2 receptor. So these blood vessels, usually the response is contraction, but not in coronary vessels. Usually coronary vessels are dilated. Because maybe you still remember the regulation of coronary vessels mainly depend on metabolized substance in the cardiac cells. Remember that? Just now I mentioned this drug also can activate beta-1 receptor, induce positive effect on the heart. So caused by this drug, the function of the heart increased. So it will has relatively more metabolized substance. So this substance stimulate coronary blood vessels. Induce that response is vasodilation. Yeah. And it can increase the blood supply to the cardiac cells. It also is helpful. So effects on the heart, just now I mentioned it is a positive effect, include positive chronotropic effects, increased heart rate, increased contraction velocity, so shorten the effective refractory period. It also has positive inotropic effect, so increase the contractility and increase the force of the cardiac cells, increase cardiac output. But usually, in fact, the heart rate, the alteration is not very obvious because, in the presence of normal reflex activity, there is direct effects on the heart rate. The direct effect is increased heart rate. This effect may be dominated by a reflex response to blood pressures. In the whole body, we have reflex in the regulation of blood pressure. Once blood pressure has an obvious alteration, the body will mobilize some mechanism to stop this alteration. So when this vasoconstriction caused by norepinephrine induce relatively higher, more obvious alteration of blood pressure increase. obvious increase. So it can decrease the functional tone, or the sympathetic tone. So at these conditions, parasympathetic nerve function predominate, act on the heart, overcome the increased heart rate caused by norepinephrine. So finally, the final alteration of heart rate, it is not obvious. Blood pressure, effect on the heart and blood vessels, it always affects blood pressure. But this drug at different dose induce different results. Blood pressure usually described by systolic blood pressure and diastolic blood pressure. And maybe you still remember from physiology, systolic blood pressure mainly regulated by heart function. And diastolic blood pressure is also mainly dominated by blood vessels, determined by peripheral resistance. So when this norepinephrine used as relatively low dose, it mainly activates beta-1 receptor in the cardiac cells. So here, I want to tell you, remember, this content is not mentioned in your textbook, but I want to tell you, you should know this. Usually, beta receptor is more sensitive than alpha receptor to agonist. This is similar to M or N receptor. M receptor is more sensitive than N receptor to the acetylcholine. But here, beta receptor is more sensitive to norepinephrine and epinephrine or others than alpha receptor. So here, when they use in low dose, these agents mainly activate beta receptor. So beta-1 increases the cardiac output, so it mainly increases systolic blood pressure. When the drug used in moderate to high dose, at these conditions, beta-1 and alpha-1 receptor all can be activated by this drug. So it increases the heart function. It also induces vasoconstriction. So the result is increased peripheral resistance, also increased diastolic and systolic blood pressure. And this increase of blood pressure, this effect caused by norepinephrine, is very potent, very quick, and transient. Why transient? Don't forget, it is one of catecholamines. Catecholamines always can be inactivated by metabolism enzymes. So their effect just lasts for several minutes, very short. So this effect is very transient. So here, based on this pharmacological effect, I want to ask you, what conditions we need to increase blood pressure rapidly? So the therapeutic applications of norepinephrine include this. So before I introduce these clinical uses, I should mention the administration route of norepinephrine. Because this drug has very strong effect on the blood vessels, induce this very potent and rapid vasoconstriction. So in any tissues, this result often lead to ischemia. And this drug also metabolizes very soon. So this drug only administered intravenously, intravascularly. The first clinical uses is shock. Here it means septic shock. Till now, maybe you haven't studied shock from pathophysiology. Maybe you have no idea no idea from shock. You have no idea about shock. So here, I explain a little. Shock is a complicated acute cardiovascular syndrome. It means critical reduction in perfusion of vital tissues. The patients usually have hypotension, oliguria, and metabolic acidosis. The major mechanisms include hypovolemia, heart failure, and altered vascular resistance. When you study shock from pathophysiology, you will study actually the shock includes several different types, like hypovolemia, it caused by hypovolemic shock, caused by heart failure, it caused by cardiogenic shock. If it is caused by infection of bacteria or virus, it caused by infectious shock. But no matter what type of shock, the patient often has hypotension. During these conditions, especially some vital tissue, because of ischemia. If this ischemia lasts for a relatively long time, it will induce some irreversible result. So try to correct this hypotension, increase hypotension. So increase blood supply to the vital tissue is really important. Because this norepinephrine can induce a rapid and strong increased blood pressure. But this vasoconstriction caused by norepinephrine is really, really potent. So we just use this drug early after diagnosis and temporarily. Use this norepinephrine. The objective of using this drug is to maintain blood pressure and maintain the blood perfusion to the vessel tissue. Once this drug used relatively longer time, it induced vasoconstriction. The final result, it also decreased the blood supply to the tissue. So we just use this drug temporarily. Blood supply to some tissue organs always determined by blood pressure. If the blood pressure is too low, it is not enough. So try to maintain. Second, used to treat hypotension. If this hypotension induced by some drug intoxication like chlorpromazine. This one, when you study antipsychotic drugs, I will teach you this. It also can block alpha receptor, so induce vasodilation, sometimes lead to hypotension. We can use norepinephrine to correct. This drug also used to treat local hemostasis, like oral administration in the treatment of upper GI hemorrhage. Just now I mentioned this drug cannot be administered orally because, in the mucous membrane, blood vessels contain too many alpha-1 receptor. This drug induces vasoconstriction. This effect is really strong and induce ischemia maybe. So we cannot use this drug orally. But when someone is suffering from upper GI hemorrhage, this is hemorrhage, we can use this orally because it induces vasoconstriction. This response of the blood vessels can close the blood vessels and stop hemorrhage. So this is local hemostasis. Okay, these are the therapeutic applications for norepinephrine. So here, I want to ask you, what are the adverse effects of norepinephrine? Clinical uses determined by pharmacological effect. Adverse effects also determined by effects. So what is adverse effects? the main response is vasoconstriction. So once this vasoconstriction is too strong and lasts for a long time, what is that result? Just now I mentioned ischemia. So the adverse effect all related to activation of alpha receptor induced. First one is local ischemic change. It is usually caused by repeated topical use of high concentrations. Maybe it caused by extravasation into subcutaneous tissues. It caused because of vasoconstriction caused by alpha receptor activation. So at these conditions, you can use alpha receptor antagonist to treat. Just use competitive antagonist to compete to bind to the alpha-1 receptor in the blood vessels with norepinephrine. Don't forget, in the splanchnic blood vessels, kidney blood vessels has relatively higher density of alpha-1 receptor. So blood supply in the kidney, it also can be affected by this drug. So the second adverse effect is acute renal failure because of vasoconstriction caused by norepinephrine. Perfusion of kidney quickly reduced. So induced oliguria. The metabolic substance accumulate in the renal tubule. So it can damage the tubular epithelial cells, induce acute renal failure. So try to avoid these adverse effects. So just because of very rapid and so potent vasoconstriction, but it also is transient. Just because of this disadvantage, so norepinephrine usually can be replaced by this drug, metaraminol. It also has another name, aramine. This drug predominantly direct-acting alpha receptor agonist, but it also acts through the release of stored catecholamines. But compared with norepinephrine, this drug caused a mild and lasting increase in blood pressure because it is not easy to be metabolized. It is non-catecholamines. So in the clinical practice, it worked as a suicidinum for norepinephrine in the treatment of early shock. Yeah, this is metaraminol, alpha receptor agonist. Okay, that's all for introduction of alpha receptor agonist. What are the effects and clinical uses of beta receptor agonist, isoprene? Let's go on. Beta receptor agonist. In this group, the representative drug is isoprene. The another name is isoprenaline. I usually used the ISO to describe this drug. This drug just mainly activates beta 1 and beta 2 receptor. Effects on alpha receptor is very, very, very weak. So we considered it as beta receptor agonist. So here, try to think of where beta receptor and beta 2 receptor distribute and their after activation, what is the functional change of the body? Beta receptor, beta 1 in the heart or kidney, beta 2 in smooth muscles or liver or isolated beta cells. Remember? Yeah. So first, act on the heart. It can activate beta-1 receptor directly, so induce positive chronotropic and inotropic actions. It induces a marked increase in cardiac output. So this positive effect on the heart is very obvious. Act on the blood vessels and the blood pressure. This drug on the blood vessels, it also can directly activate beta-2 receptor, promotes smooth muscle relaxation, especially the blood vessels in skeletal muscle. The blood vessels supplying to the skeletal muscle usually dilate. Even renal and mesenteric vascular beds, they also can be dilated. So, effects on the blood pressure, it induces a fall in diastolic and mean arterial pressure and a lesser decrease or a slight increase in systolic blood pressure. Because it has positive effect on the heart. This result is increased systolic blood pressure. So it mainly affects the diastolic blood pressure. Beta-2 receptor also resides in smooth muscle of IV. So activate beta-2 receptor here directly induce bronchodilation. This result in the treatment of asthma like that disease, it is very useful. This bronchodilation facilitates breathe. So I think now, based on these pharmacological effects, can you guys clinical uses? Yeah, the main effects caused by isoproterenol, mainly in the heart. So there are two conditions of the heart problems we can use isoproterenol to treat. The first one is cardiac arrest. This drug can be injected directly into the ventricle. Especially, it also can be used in combination with norepinephrine. Norepinephrine also can directly activate the beta-1 receptor. So usually they can use it together. And this drug mainly used to treat some cardiac arrest caused by heart problems, like very low rhythm of heart rate and very serious AV blockade or SA node failure, like that cardiac arrest. We can choose this isoproterenol to stimulate the cardiac cells to recover normal rhythm. The second condition is serious or moderate AV blockade. Yeah, when I taught you atropine, I said you mainly study two agents used for the treatment of AV blockade. One is atropine. It blocks M receptor and then increase the sympathetic nerve function, decrease the vagal nerve function. This one, just the opposite. It can inhibit the it mainly increases the function of the sympathetic nerve by activation of beta-1 receptor in the cardiac cells. So there are different. If this AV blockade is caused by decreased tone of sympathetic nerve, you had better use isoproterenol, not atropine. Yeah. And it also induces smooth muscle dilation, especially in trachea. So bronchodilation caused by isoproterenol. This result is useful in the treatment of acute bronchial asthma. This drug can be administered sublingual. And intravenous injection is very useful for acute asthma. Now, of course, in the treatment of acute asthma, this drug, it also has effects on the heart. So for the patients with cardiac disease, also has asthma. In the treatment of acute asthma, pay attention to the effects on the heart. Yeah, this drug, it also can be used to treat shock, especially cardiogenic shock or septic shock with low cardiac output. This drug can stimulate beta-1 receptor in the heart, so increase cardiac output. To correct this shock situation, it is helpful. But, this drug must be used after the blood volume corrected. If the patient has hypo blood volume, hypovolemia, you should first correct that problem first. Advanced. Okay, because this drug in the treatment of acute bronchial asthma effects on the heart, it is adverse reactions. So we have some selective beta-2 receptor agonists. So metrol, albuterol, and terbutaline. These drugs has very, very weak beta-1 receptor activation. So they can be used to treat asthma, including chronic or mild or acute asthma. Because this drug can be administered by inhalation or spray like that, or sublingual spray administration. It can take onset very fast, and it also is very potent. This is selective beta-2 receptor agonist. When you study the drugs used to treat asthma, you will study this drug again. Yeah, now this is albuterol, terbutaline, Okay. We also have some selective beta-1 receptor agonist. The representative drug is dobutamine. This drug mainly activates beta-1 receptor. Actually, it has relatively higher effect, the stronger effect on the positive inotropic actions. This is stronger than positive chronotropic actions compared with isoprenaline. So compared with isoprenaline, this drug induces less tachycardia, mainly increased cardiac contractility. The increased cardiac output is very useful. So this drug can be used to treat myocardial infarction with heart failure. Yeah, when you study the drug used to treat congestive heart failure, you will study this drug again. This is selective beta-1 receptor agonist, dobutamine. Yeah. Okay, that's all for this class. I have another question for you to preview the next section. What are the effects and clinical uses of alpha and beta receptor agonist? What are the effects and clinical uses of alpha and beta receptor agonist? In this class, I mainly introduced the alpha receptor agonist and beta receptor agonist. So how about alpha beta receptor agonist? Okay, thank you.